Assalamualaikum warahmatullahi wabarakatuh. Good morning, all participants and jury of this free paper contest of annual scientific meeting, Indonesian Ophthalmology Association. This morning, we will have a free paper contest of 6 participants, Dr. Cecilia, Dr. Rahma Sadida, Dr. Raisya Pratiwi Indrawati, Dr. Brenda, Dr. Rifa Irlinda, and Dr. Nimade Oka Handayani. Today, jury is myself, Dr. Muhammad Shauki, and second jury is Dr. Ani Ismail. All participants will have their pre-recorded video played and then continue with Q&A session for 2 minutes. Okay. The first presentation is started with Dr. Cecia Anggraini with coding of Inanos FPGRX. To the committee, we can start the presentation. Thank you.
My name is Cecilia Anggraini, and in this opportunity, I would like to present my study about validation of the Indonesian version of the Graph Ophthalmopathy Quality of Life Questionnaire and its association to clinical activity and severity of the disease. Graph ophthalmopathy is a very devastating disease, and it can affect the quality of life of the patient. But how is the quality of life? UGOGO itself already recommend us to use the Graph Ophthalmopathy Specific Quality of Life Questionnaire as the instrument. Lumong Satien already used this instrument and validated in the Thailand version and show good result. How about in Indonesia? Assessing the quality of life of the Graph Ophthalmopathy patient has not become a routine because there is no valid questionnaire to be used. Therefore, in this study, we would like to present a valid and reliable Indonesian version of the GOQL questionnaire as the first instrument to be used in Indonesia and assess the relationship between clinical activity as well as the severity of GO and the quality of life. The methods start from the translation and also the synthesis, and then we did the focus group discussion where the product will be the pre-final questionnaire, and after that it will undergo the cognitive debriefing and tested to the 52 respondents that already calculated based on the sample size in Neuro-Ophthalmological Clinic from October 2022, and then did the test pretest validity after 2 weeks. In the phase 1 content validation, we got the CVI or the content validity index about 1, which is higher than Thai version. Our instrument has become a cross-cultural communication tool to convey the quality of life of graph patients in Indonesia. Most of the respondents in the study, about 39 years old and also female, and in the clinical condition euthyroid status, no complaint in the visual acuity impairment, inactive state, and mild severity. Here are the questionnaire that already adapted and translated into Bahasa. In the visual function subscale, the majority of respondents didn't perceive daily activity limitation. Meanwhile, in the appearance subscale, the majority of respondents are aware of an obvious difference in appearance. Here we can see the corrected item total correlation and Kornba alpha, which are valid and reliable. So our instrument validity and ability test was really good. These are the GOQL score in our respondents. And the Kornba alpha and also the interclass correlation showed a very good reliability. Meanwhile, in the p-value, it showed insignificant differences. Means the first measurement and also the second measurement, there is no difference. If we use this instrument or questionnaire repeatedly, it will show the same result. Disease with fluctuating clinical condition may cause the low instrument reliability compared to the stable patients. However, Hope said that in the graph ophthalmopathy, it might be quite stable because the quality of life will change after 6 months of treatment. Here are the association between the quality of life and also the clinical activity score. The clinical active GO lowered the patient's quality of life on the appearance and total subscales. The clinical activity score was assessed using the CHAS instrument. This instrument assessed the GO information, for example, eyelid edema, conjunctival injection, also chemosis. These signs will manifest in the appearance, and it will alter the appearance. Therefore, the quality of life on the appearance subscale might be affected by the clinical activity score. Zingpi and Velajalin also found out there is a negative relationship between the CHAS and also the GOQL values, which is the same in the study. Here are the association between the quality of life and also the disease severity. The relationship between severity and GO patients' appearance subscale quality of life was significant. Zingpi found in his study there's an inverse relationship between the degree of severity and GO-QOL value, which is the same in this study. Graph of ophthalmopathy severity was assessed using the UGOGO classification. One of the criteria, for example, is soft tissue involvement. If there is manifestation in the soft tissue involvement, if it might be affected in the appearance. Therefore, the quality of life in the appearance subscale might be affected by the disease severity. What about the insignificant association between quality of life of GO patient on the visual function subscale with the clinical activity and disease severity? Because most of our patients was in the mildly inactive state. And then there's an outlier data, which is in here we can see the visual functions GO-QOL score was very high, about 91. But then the minimum score was 18, while the maximum score was 100. The very range of this score will cause the non-normal distribution, while the non-normal distribution will cause the data become not statistically significant. The patient's clinical condition sometimes doesn't affect the patient's quality of life. Therefore, the clinical condition cannot be the only indicator of the success of each individual treatment. The use of Indonesian version of the GO-QOL questionnaire should be used in accordance with the clinical practice guidelines for the management of grave ophthalmopathy, so the ophthalmologist can determine the treatment needed by the patient. The conclusion of this study are, the study produced a valid GO-QOL questionnaire in Indonesian with the high validity. The study produced reliable Indonesian GO-QOL questionnaire with the high reliability. Active grave ophthalmopathy worsens patient appearance and overall quality of life. The higher the severity of grave ophthalmopathy, the worse the patient's quality of life on the appearance and overall subscales. Thank you.
Thank you, Dr. Cecilia, for your presentation. I have one question. In table number 5, you show that sight-threatening disease severity have visual function score about 100. My question is, what type of bias can occur in this study? Because if we know that sight-threatening disease severity cannot have visual function score until 100, what type of bias?
Okay, thank you. Good morning, doctor. Thank you for the question. So just want to make sure. So for the table of this disease severity, doctor, is that the questions about why the GO-QOL score is about 100? In the disease severity table, doctor, is that the table?
Yes, in the table number 5.
Okay, maybe it's not only about the bias, doctor. And this is about talking about the quality of life. So the quality of life is very subjective. So it's not talking about the bias, but it means it shows that each individual of the patients has a different perceptions towards the disease. For example, one of our subject, they have like very severe stage, and also, but they give like 100 score, means that he has a good perceptions toward the disease. He doesn't have like the disease. Maybe the clinical condition is really bad, but then for him, he doesn't have like the problem with the daily activity, and also for the appearance. This patient doesn't feel that it's annoying for them. So it's not a bias, but it shows that the subjective perception that although the severity of the disease is very high for us as a practitioner or the clinician, but for the patient itself, it doesn't affect them. So it's not about.
Okay, time is over. Thank you for your answer, Dr. Cecilia. Okay, next we move to the next presentant, Dr. Rahma Sadida with coding of INAPOS FPGR10. To the committee, we can play the video. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Rahma Sadida as ophthalmology resident. In this opportunity, I would like to present my research about surgical outcome of strabismus correction in large angle esotropia. Esotropia is a type of eye misalignment where one eye deviates outward. In this study, we define large angle esotropia with a deviation of more than 50 prism diopter. Treatment options and success rate in large angle esotropia surgery were very widely. Surgical treatment of esotropia typically consists of bilateral lateral rectus muscle resection or unilateral lateral rectus muscle resection combined with medial rectus muscle resection, while rod deviation may require surgery on 3 or 4 muscles. This study aims to evaluate the surgical outcome of strabismus correction in large angle esotropia in Dr. Karyadi General Hospital. Methods of this study is retrospective study. Patients with large angle esotropia who underwent strabismus correction from January 2020 until December 2022. To define angle deviation, we use prism and alternate cover test. Krimsky test used for uncooperative patients. Snellen chart and cycloplegic refraction were used to assess visual acuity and amblyopia condition. Sensory deprivation were obtained from segment anterior and fundus examination. There were 162 patients registered with exotropia, 103 patients who did not show up for follow-up in 1 or 3 months, and patients which had incomplete medical record were excluded. 59 patients with large angle esotropia were included in the study. Large angle esotropia subjects were composed mainly 53% of women. Study subjects were divided into age range. The most study subject was 6 to 11 years old with the average 16 years old. Study found that 10% subjects had amblyopia. Sensory deprivation was found in study subject which divided into cataract, pupil atrophy, and also glaucoma. The most angle deviation was more than 60 prism diopter. Study subject underwent strabismus correction surgery and came follow-up at first month. By 3-month post-operative visit, all patients reported orthophoria. Figure 1 showed preoperative photograph of a patient with 70 prism diopter exotropia. 3 months post-operative photograph of patient showing good alignment. In figure 2, we can see photograph A that show preoperative photograph of a patient with 65 prism diopter exotropia. Picture B showed immediate post-operative photograph of patient showing satisfactory alignment with 2 rectus surgery. Picture C showed first month visit to clinic photograph of patient showing good alignment too. This study comprised 59 patients aged 1 to 53 years old. This is consistent with largest reported studies that stated that the age of large angle esotropia offer a wide range. It has been previously studied that esotropia dominantly presents in women. Similarly, we found that esotropia is dominant present in women too. 10% study subject amblyopia with a severity moderate to severe amblyopia. Amblyopia develops in approximately 50% of children who have esotropia, not exotropia. This was consistent to the study that the minority of study subjects had amblyopia. The most common cause of visual deprivation amblyopia is congenital or early acquired cataract. Our study exposes that statement where there were 11 study subjects had sensory deprivation, including cataract as risk factor. Previous study reported success rate 71 to 83% in large angle esotropia surgery. It was similar to this study. 100% of all patients reported orthophoria on 3 months visit post-procedure. This study has several limitations that should be noted. It was a retrospective study with a relatively small sample size. The onset of exotropia was based on patient history, which can be subject to recall bias. No follow-up until 6 months visit post-operatively and also not in the same surgical procedure. Finally, there were variation in the follow-up times among individual cases. This study found the outcome of strabismus correction for large angle esotropia is satisfactory. 2 or 3 muscle surgery provides an effective means for treatment of large angle esotropia. Further research can be carried out long-term evaluation until 6 months post-operatively to evaluate is there any recurrent or residual deviation after strabismus surgery. Thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Rahma Sadida, for your presentation. I have one question. In this paper, I note some contradictory statement. In the introduction, you stated that large deviation needs surgery on 3 or 4 muscles. But in the conclusion of your study, 2 or 3 muscle surgery provide effective treatment for large angle esotropia. Why this contradictory statement occur, and what is the criteria for operating only on 2 muscle? Thank you.
Thank you so much for the question, Dr. Muhammad Sauki, and the opportunity. So the indication for the surgery is defined based by patient. It's indicated by the angle deviation of each patient, and then we can conclude we can do 2 muscle surgery or 3 muscle surgery. From the introduction and from the lecture that I read before, for large angle esotropia, I need 3 until 4 surgery. But my study, from the study with 2 and 3 muscle surgery, can give satisfactory result, doctor. Thank you.
Any reason why in this study we can only operate on 2 or 3 muscle? Any reason?
Sorry,
yeah. Yes, any reason why this is different with the literature?
Yes, as I said before, it depends on the condition of the patient and the angle deviation of each patient in one eye and the type of strabismus, intermittent or constant strabismus. It's so we decided the operation by patient.
Thank you, Dr. Rahma, for your answer. Next, we move to the next presentant, Dr. Raisya Pratiwi Indrawati, with coding in APOS FPGR22. To the committee, we can play the video. Thank you.
Good afternoon. Thank you for the opportunity given. My name is Raisa Pratiwi from Universitas Padjadjaran Cicendo Eye Hospital. Today, I would like to present a free paper entitled Retinopathy of Prematurity in Tertiary Rural Eye Hospital in Indonesia, Characteristics and Management. As introduction, ROP is a vasoproliferative disorder of retina in premature infant. Globally, there were almost 200,000 children with ROP, and 20,000 of them had severe visual impairment and blindness. In Indonesia, ROP were found in 18 to 30% of infants under 32 weeks. There were several risk factors of ROP, including gestational age and birth weight. ROP were classified by its zone and stage, which will further determine its management. Thus, the study is aimed to describe the characteristics and management of patients with retinopathy of prematurity at the National Eye Center Cicendo Eye Hospital. It was a retrospective descriptive study using the medical record data from Cicendo Eye Hospital. Inclusion criteria were new patients that coded as ROP with initial visit during the period of January 2018 to December 2020. Exclusion criteria included those who were not diagnosed as ROP but coded as ROP and those with incomplete data, especially the data of birth weight and gestational age. There were several variables in the study, including demographic data, history of birth, and clinical characteristics, which taken from the medical record data, especially history taking and physical examination. There were 299 patients included in this study, but after the exclusion, the total sample were 177 patients. From demographic data, we can see that most of the patients in this study were boys, mostly come after 3 months old, came from West Java outside Bandung, were referred, and were BPJS users, or National Health Coverage users. From clinical characteristics, most of our patients were born at 28 to 33 weeks of gestational age and has birth weight less than 1.5 kilogram, mostly had history of oxygen supplementation. For the clinical characteristic of ROP itself, most of them were having bilateral ROP in stage 5, thus conservative management were mostly given. Here we can see that most of our patients were still in stage 5, regardless their gestational age or birth weight. For the management of ROP, the patients in stage 1 were mostly observed first. Stage 2, 3, and 4A were treated by intraocular laser. Stage 4B treated by PPV, and stage 5 were conservatively managed. For discussion, ROP is the leading cause of preventable blindness in childhood. Therefore, screening is very important as initial management. There are several guidelines in several countries regarding the screening parameters. However, the screening parameters in different regions cannot be equated, but it can be modified as needed. Thus, it is very important to know the characteristic of ROP patients in each region. Here we can see that most of our patients came after 3 months old and were mostly BPJS users. Previous study by Siswanto et al. Mentioned that there was a decrease in the incidence of ROP compared to previous years. Probably it's due to the existence of insurance, which increased the chance of patients getting services in the hospital, thus reducing the number of ROP. However, we can see here that most of our patients came in more severe cases compared to previous studies. Most of our patients has birth weight less than 1.5 kilogram, but 1/3 of them were more than that. Hence, it was suggested that in our country, ROP screening not only done in very low birth weight infants, but also in bigger infants. We have different modalities of treatment, but for type 1 ROP, intraocular laser was still being the mainstay of treatment. It was in line with previous studies that showed high success rate of intraocular laser for type 1 ROP. There are several limitations, including the data which taken only from history taking, which could lead into bias, and also the examination that were done by more than one ophthalmologist. As conclusion, patient in this study has mean gestational age under 30 weeks, with mean birth weight less than 1.5 kilogram, mostly came after 3 months old in stage 5 ROP, and mostly were managed conservatively. Thank you for your kind attention.
Thank you, Dr. Resha, for your presentation. I have one question. In your paper, I noticed that in table 4 and 5, I got impression that the stage 5 percentage is highest on baby with more than 37 weeks, about 100%, and more than 2,000 gram weight, about 75%. I got impression like that when I see your table 4 and 5. What is your comment about this? What is wrong about the table? And in stage 5 patient, majority have only observation. Why only 2 patients have vitrectomy? Thank you.
Thank you, doctor, for the question. Actually, in our center, most of the patients came in late stage, in stage 5, even though they are in high gestational age or high birth weight. But in general, all of them had a stage 5 when they are coming to Cicendo. There are actually several factors that might affect that. The first one is probably due to the accessibility. So the patient who come to our center actually come from distant area. As we can see it in other table, most of our patient is from outer Java, outside West Java, from Sumatra, Kalimantan, or even Papua. So they came to Cicendo after the birth, after 3 months old. So it's due to the late referral. And also, even though they are mostly BPJS users, but we can see that they are from distant area that may take high cost to come to our center. So it also caused the late referral. Other than that, because ROP itself is happened in the premature children, we can see that a prematurity itself is a high-threatening condition, is a life-threatening. Thus, the life-threatening condition is not a priority. And mostly we're observed first because anatomically or physiologically is not feasible to treat, doctor. Thank you.
Thank you, Dr. Reza, for your answer. We move to the next presenter, Dr. Brenda, with coding of INASORB FPO7. To the committee, we can play the video. Thank you.
Bismillahirrahmanirrahim. Good afternoon, doctors. Allow me to present my descriptive study with the title of Prevalence and Retrospective Review of the Lower Eyelid Ectropion in Tertiary Hospital in Indonesia. As introduction and methods, ectropion defined by the aversion of the eyelid edge and exposure of conjunctiva and occasionally the cornea. It commonly affects the lower eyelids. There are 5 types of ectropion based on etiologies. Demontiano et al. Reported ectropion prevalence rate were 2.9% for involutional, 1.6% for symmetrical, and 0.2% for paralytic, and 0.1% for mechanical ectropion. From the Blue Mountain study in Australia has shown a strong association between aging and the prevalence of ectropion, where they said that remarkable increase prevalence of ectropion from 0.3% in people aged less than 60 years to 16.7% in people aged more than 80 years. The initial management of ectropion in this is the administration of lubricant in the form of eye gel and eye drops. In advanced cases, surgical correction can be carried out according to the underlying pathophysiology. In pollution ectropion, horizontal laxity of the lower eyelid occurs. Surgical procedure that can be done is a big procedure, formal ectropion, lateral tarsal strip, and the Kuhn-Szymanowski procedure for severe laxity. In medial involutional ectropion, medial cantopexy, and diamond excision, also laxity procedure can be performed. In paralytic ectropion, where there is a paralysis of the orbicularis muscle, causing orbicularis atony and tarsus allocation occurs. Mild cases can be treated with lateral tarsal strip. Recurrent cases can be done with cartilage graft fixation to the tarsal plate to the orbital rim, and for medial ectropion can be done medial cantopexy or laxity procedure as described by the previous slide. In cicatricial and congenital ectropion, there is a shortening of the anterior upper lamella. For example, in case post-blepharoplasty, a cicatricial release can be performed. Subcutaneous fixation to the lateral peristeum and lateral tarsal strip are performed, and in case of chemical trauma, the treatment option that can be performed is skin graft. This is a pre- and post-operative picture of the surgical correction of involutional, paralytic, and cicatricial ectropion. The problem formulation from this research is that epidemiological data of ectropion cases in Indonesia is limited. Also, no epidemiological data from the tertiary hospital in Indonesia, so this study was conducted to evaluate characteristic, profile, surgical outcomes, and success rate ectropion surgery in 3 tertiary hospitals in Indonesia. This study research design is descriptive retrospective, conducted from August to October 2022, and population sample is patient with diagnosed ectropion from 2017 to 2022 or 5 years, and the research subject is population that meet the inclusion and exclusion criteria. This is the inclusion and exclusion criteria of the study. We are going to result in discussion the flow of this study by searching through electronic medical records. We obtained 141 or 166 96 patients with a diagnosis that match of ectropion. The following are demographic characteristics of this study. In this study, the majority of the sex were male, in line with studies by Michelle Chua and Chalaki et al. That said, also in Blue Mountain study, there was ectropion was dominated by men aged over 60 years that can be related by physical activity and work factors in men who expose more to sunlight compared to women. And old age was one of the risk factors of ectropion. Involution ectropion was found most in the study, around 44.7, in line with number of patients over 60 years who were found more in the study. In this study, also the most common type of paralytic ectropion caused disruption of the cornea, and most common cause of cicatricial ectropion was history of previous blepharoplasty operation, in line with Chua et al. In Singapore. From this table, we can see involutional and mechanical ectropion have a success rate 100%, paralytic ectropion 91.7%, and cicatricial ectropion 88.9%. Type surgery most performed is lateral tarsal strip with a combination with other procedure. Kim et al. Is reported that lateral tarsal strip without combination with any procedure can be an option for mild ectropion. Pedok et al. Also reported that there is a medial medial laxity, lateral tarsal strip combined with medial canthus application can be done, as well as paralytic ectropion combined with rasorapy. In this treatment outcome, there were 47 patients or 33.3% patient who underwent surgery, 12 paralytic, 3 mechanical, 18 cicatricial, and 14 involutional ectropion patient. This is different with study by Chua, Guthrie, and Carter et al., where they said ectropion corrective surgery is 3 to 6%. Most of the patients undergoing surgery are cicatricial and paralytic ectropion due to Bell's palsy and occurs in elderly patients. This is the duration of less than 2 months operatively. There were 2 cicatricial ectropion and 1 paralytic ectropion who experienced recurrence, as well as 6.4% and 12.9% with a duration of more than 2%. As a conclusion, ectropion mostly affected male and aging population in this study, involving 3 eye hospitals in Indonesia, and involutional ectropion can be most etiology of this study. No significant complication post-operation during 5 years period with less recurrence rate, primarily caused by paralytic and cicatricial ectropion. Thank you for your attention. Good afternoon.
Thank you, Dr. Brenda, for your presentation. I have one question. In this study, majority of patients with involutional ectropion didn't undergo surgery. Despite the success rate of 100%, what type of bias can occur that can affecting the result? Thank you.
Thank you for the question. For the most of the patient of ectropion came with complaint with epiphora, and most of the patient also if the epiphora not too bad, he didn't want to perform the operation. And the patient who wants to perform the operation is one with chronic of the complaint. So a person who who does the operation with a chronic of the ectropion complaint. And bias of this case is relative minimal because of the all of the case was performed in late stage of the ectropion effect. Thank you.
So the rest of the patient is only treated with medication therapy?
Yes, most of the patient without the operation with medicated therapy.
Yeah, maybe the treatment with medication can be shown in the table beside the surgery, so we can compare what type of treatment suitable for the patient. Okay, not only surgery. Okay, thank you, Dr. Brenda, for your answer. Next, we move to the next presenter, Dr. Riva Erlinda with coding of Inarvos FPGR3. To the committee, we can play the
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Doctor, for the opportunity. My name is Riva Erlinda. Let me present my paper with title The Difference of Predicted Refraction and Final Refraction using Pareto Universal Formula and SRKT formula in myop patient after vacuum-emulsification and IOL implantation at Dr. Karyadi General Hospital, Semarang. For introduction, myop is one of the highest prevalence eye disease in the world. Myop refers to myop with lens refractive power of more than -6 dioptry or axial length more than 26 mm. The prevalence is projected to affect 10%, about 925 million population by 2050. The development of vacuum-emulsification technique with small incision and availability of biometry measurement can reduce postoperative hyperopia. Therefore, calculation of intraocular power is crucial to achieve optimal visual outcome. While myop could lead to inaccuracy of IOL strength calculation, which could cause postoperative hyperopia, which decreases patient satisfaction. Pareto formula, the fourth generation formula to determine strength of IOL to be implanted, has been considered capable of offering lower difference between predicted refractive outcome and final refractive outcome of patient than the SRKT formula due to its detailed calculation. Until now, there has yet to be any research on the difference between the predicted refractive outcome and the final refractive outcome using these two formula at Dr. Karyadi Hospital. So this study aims to show the difference between the predicted refractive outcome and the final refractive outcome of patient using the Pareto formula and the SRKT formula in high myop patient who have undergone vacuum-emulsification and intraocular lens implantation at Dr. Karyadi Hospital, Semarang. This analytic observational study was conducted at Dr. Karyadi General Hospital, Semarang from January 20 and 21 until January 20 and 22. The study was conducted retrospectively using medical records following these inclusion and exclusion criteria. Patients who underwent vacuum-emulsification At the valid biometry measurement data using IL measure advanced technology V7.5, at a record of the implant IL power and patients who follow up 1 month post-operative were included in this study. Patients who experience intraoperative and post-operative complications had a central corneal abnormality, had a history of previous corneal or intraocular surgery, had a history of glaucoma, and patients with intraocular lens implantation outside the back were excluded from this study. Normality test using Safirovic and one sample t-test is used to assess whether the difference between the refractive prediction and the final refractive outcome of patient using Barrett 2 and SRKT formula significantly differ from zero. This study included 35 eyes from 23 patients with high myop. The majority of patients were female with average age about 33 years with mean axial length about 29 mm. The Pareto formula had a mean difference in refractive prediction closer to zero compared to SRKT. One sample t-test shows significant mean difference between the difference in refractive prediction of Pareto and SRKT with zero. In study by Abulafia et al., the Barrett-2 formula had the lowest predictive difference of 0.26 dioptry. These findings are consistent with the study of the study. The difference in prediction of refraction of the Barrett-2 formula with the final outcome of the patient refraction was smaller compared to the SRKT formula. Some of the limitations of the study include the limit number of samples. It's hoped that future study can use a larger sample size. And second, the study conducted retrospectively. Prospective cohort study in other population is needed to confirm the authentic of a result. And then, furthermore, this study didn't separate different IL material implanted, which could contribute to variation in final refractive outcome. Further study with the same IL material could be conducted. In conclusion, the Barrett-2 formula has a lower difference between predicted refractive outcome and the final refractive outcome of patients with high myop than the SRKT formula. Thank you, Doctor, for the opportunity.
Thank you, Dr. Riva, for your presentation. My question is, we know that SRKT is the third generation formula, while the Barrett Universal 2 is the fourth generation formula. Why you compare the formula in the different generation? Why don't you compare in the same generation, like Barrett Universal 2 with Kane or Olsen formula? Thank you.
Thank you, Doctor, for the question. Sorry, Doctor. In my study, I compared SRKT and Barrett-2 because from the previous study, many studies compare the SRKT and the Barrett-2, but in Karyadi, there is a study about it. So I will to know in high myop if we use the SRKT and the Barrett-2, Doctor.
But we already know that the fourth generation is better than the third generation. Why do you repeat it again? Why don't you test the same generation formula like Olsen or Kane with Barrett? So in this study, you only repeating the same study before.
Yes, sorry, Doctor. Let me answer. Because in Karyadi itself, we usually use Barrett-2 and the SRKT for the patient with high myop, Doctor.
Yes.
Like that, Doctor.
But Kane and Olsen is available online, so you can use it free for online. So this may be a limitation for the study. Okay.
Yeah, thank you, Doctor.
Okay, thank you for the answer, Dr. Riva. Next, we move to the last presenter, Dr. Nimade Oka Handayani with coding of IGS FP01. To the committee, we can play the video. Thank you.
Thank you, moderator. Thank you, doctors, for allowing me to present my study with title Prevalency and Characteristic of Secondary Glaucoma After Keratoplasty in GACI Hospital, Kedoya, MN. Keratoplasty is a common procedure carried out to treat various corneal disease. And this is the definition of post-penetrating keratoplasty glaucoma. Understanding the characteristic of patient undergoing keratoplasty can provide insight and benefits for preventing such complication. Therefore, this study aimed to describe the prevalence and characteristic of secondary glaucoma after keratoplasty. The design of this study was retrospective cross-sectional, and this is the inclusion and exclusion criteria. We divided the patient into 3 separate groups with transient glaucoma, persistent glaucoma, and no glaucoma. Ophthalmic examination included visual acuity, slit lamp examination, and tonometry. A total 211 eyes from 211 patients were included in the study, and this is a baseline study characteristic in table 1. From this table, PKP was the most frequent type of keratoplasty, and persistent secondary glaucoma occurred in 25 eyes. From this table, the increased IOP mainly occurred 3 months after surgery. The highest value of IOP measurement was observed in 1 week post-operation. There was significant difference in graft failure incidence between transient, persistent, and no glaucoma group. Secondary glaucoma may possess possible risk in the incidence of graft failure. From this table, visual acuity was improving throughout the study. In 25 eyes with persistent secondary glaucoma, IOP was failed to control in 14 eyes despite maximum medical therapy. For the discussion, in this study, PBK was the most common preoperative diagnosis. And the pathophysiology of post-PKP glaucoma was considered to be multifactorial. And this is the main contributing factor causing rise in IOP after the second limit. The main cause of IOP rise after dark commonly caused due to topical steroid use. Uncontrolled postoperative IOP is major risk for the cause graft failure after keratoplasty. In this study, BCVA tend to decline during 1 week post-operative, but showing relative improvement in 1 year post-operative period. And this slight decline in visual acuity might be caused by corneal edema and ongoing inflammation. The reported success rate in IOP control with mitomycin trabeculectomy in patients with secondary glaucoma after keratoplasty is 67 until 91%. And a retrospective study has reported that the success rate of glaucoma drainage device in controlling IOP reaches 85%. Early diagnosis and management of secondary glaucoma after keratoplasty can reduce post-keratoplasty complication rate and improve outcome. And for the conclusion, the prevalence of persistent secondary glaucoma after keratoplasty in this study was 11.8%, and there was significant difference in graft failure incidence between transient, persistent, and no glaucoma group. Secondary glaucoma may possess possible risk in the incidence of graft failure. The limitation of this study was its retrospective nature, conducted on available data, varying follow-up times, and different IOP measuring instruments. Further study is encouraged involving other variables or at higher level of study and with longer follow-up times. Thank you.
Thank you, Dr. Oka, for your presentation. My question is, in your paper, you state that secondary glaucoma is an important factor for graft failure after the procedure. But in table number 3, I noted that the graft failure rate is higher in the patient with no glaucoma than with in persistent glaucoma. Can you explain about this? Thank you.
Thank you, doctor, for the question. I will try to answer. For the condition in transient and no glaucoma with graft failure may become in patient with rejected from the donor body or with the not good condition on the graft donor. So also some disease that based on disease that indication make an indication to be a failed graft or graft failure, like maybe a ulcer or some disease that make the more risk to be a graft or failed graft failure or failed graft, doctor. And from the transient, maybe more than like treatment for the graft from the patient is not good. So and variation of the IOP. From the literature with acute or chronic IOP can be a risk of factor to be a graft failure, doctor. Thank you.
Okay, thank you, Dr. Oka, for your answer. We already finished all presentation from 6 presenter. Thank you for the committee, Dr. Ani Ismail, and all of the participants for joining this session today. All the participants can leave this Zoom meeting, and we can close this session with Alhamdulillah. Assalamualaikum warahmatullahi wabarakatuh.
Izin Dokter Ani, sudah boleh dimulai nih dokter?
Oke. Assalamualaikum warahmatullahi wabarakatuh, all participants and committee. My name Ani Ismail from Universitas Sriwijaya from this session, and I become the first jury and moderator. And also the Dr. Kamala Sayuti from Universitas Andalas as the second jury. Let's begin the first presentation. Dr. Rina with Illinois free paper GR 2015. 15 paper 3. Thank you. Please, the first presentation, Dr. Rina.
Greetings, ladies and gentlemen. My name is Triana. Our theme brought up the theme A Glimpse of the Future in Indonesia, Fecal Microbiota Transplant as a Therapeutic Strategy for Uveitis. Uveitis remains one of the leading vision-threatening diseases responsible for 25% blindness in the developing countries. In Indonesia, Ladistianor et al. Revealed that majority of uveitis cases are of unknown case. Together, idiopathic and non-infectious origin made up the most common uveitis etiology in Indonesia. Although ranging from topical to systemic therapy, from anti-inflammatory groups of drugs to immunomodulatory drugs, available treatments for idiopathic and non-infectious uveitis were only targeting symptoms relief, with long course duration, which sometimes are not well tolerated. This leads to the question, is there any target-specific treatment available? Us, as the future young ophthalmologist, would like to offer an unprecedented way in the long-standing uveitis problems, proposing fecal microbiota transplant. Here's the concept that we offer. To see human body as a fast changeable ecosystem for trillions commensal microorganisms living most abundantly in the gut that are heavily influenced by internal and external factors. This concept has altered how the medicine works in practice. Instead of combating microbiome as harmful targets, we nurture and maintain in their homeostatic balance. FMT offers a non-conventional way in modulating and repopulating the microbiomes to its homeostatic state. This is the methods for our literature review. Studies investigating FMT in autoimmune and idiopathic uveitis involving animal and human subjects were included in this review. Reference lists of retrieved articles were manually checked for potentially eligible studies. The studies included ranging from January 2001 to March 2023. The types of study included were meta-analysis, systematic review, randomized controlled trials, literature review, cohort, and case control study. All accessible and relevant studies in English or Bahasa Indonesia were included. Study selection and data extraction was carried out by independent lab by 2 investigators, with discrepancies resolved in consultation with the senior authors. Using mesh terms and Boolean strategy, we search for these keywords from 5 e-databases: PubMed, Clinical Key, EBSCOhost, Google Scholar, and Crossref. This is our schematic study selection, which yielded into 48 studies which are thoroughly reviewed in this literature review. Preclinical and clinical studies have established a gut-eye axis. Multiple studies have revealed that certain ocular diseases in both mice models and humans exhibit changes within the gut composition. And there were no significant differences in gut composition of patients with autoimmune and idiopathic uveitis. In mice models, gut microbiota provides signals directly to the retina-specific T cell receptors, leading to autoreactive T cells. This initiates uveitis with 2 possible mechanisms. 1. Gut microbiota underwent molecular mimicry as retinal antigens, Or 2, they play a supporting role in providing innate signals, initiating uveitis. The use of FMT in ocular diseases has been done in mice models, showing favorable improvement in clinical symptoms. In human, FMT has been recently approved by the FDA as a therapy for recurrent Clostridium difficile infection by this April. RCT studies for FMT in humans have been conducted in multiple diseases ranging from gastrointestinal to rheumatology disorder. However, studies for uveitis have been limited to animal models only. So how may Indonesia progress in the future? As the background has matched, we propose localized FMT production and domestic stool bank arrangement with this mechanism: donor fecal extraction, FMT production, and storage in the stool bank. To conclude, FMT is a potential target-specific therapy for idiopathic and non-infectious uveitis in humans. Indonesia needs to develop our own FMT studies to further proceed as a novel therapeutic strategy in uveitis. Thank you.
Thank you, Dr. For you. Is there any study in Indonesia about FTM? What we need to prepare for that?
Thank you very much, Dr. Ani Ismail, for your question. Currently, in Indonesia, there is no clinical studies regarding FMT. However, there have been some literature review, but in the segment of internal medicine, particularly in the gastrointestinal division, but not in the other. So I guess for FMT in ocular or ophthalmology segment, we brought up this theme to you as a novel study in ophthalmology department. And what needs to be done in the future? Well, there are still many things to be prepared because this is still a review. There is still no clinical settings or clinical protocols regarding this study. So maybe we can start from a clinical study. We can start in human, but I think before that we need to gather together from multiple centers to create a protocol on how we should done the clinical study settings.
Okay. Thank you for answer, Dr. Triana. We come very excited with your presentation. Thank you.
Thank you very much, Doctor.
Next presentation from in a short pre-paper GR 29.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Doctor. Thank you for the opportunity. I'll write my full paper entitled Clinical Characteristic, Causality, and Evaluation of Eyelid Laceration Surgery in Karate General Hospital in Semarang with me as the author and supervised by Trilaksana Ophthalmologist Consultant. For the introduction, out of the large number of trauma incidents, not a few have the potential to result in injury to the orbital and periorbital region, which can cause problems by extending beyond the side of the dilation to the interior of the head and face. Eyelid laceration appear to be understudied in terms of adequate epidemiological research among all injury sites. Study need and potential reduce the prevalence of such trauma-related incident in high-risk patients by implementing a number of safety precautions at workplace. The method of this paper, the data in the study came from patients who underwent eyelid laceration surgery from March 2021 to March 2023. The data collected include gender, age, temperature, cause of laceration, laceration region, grade, length of evaluation, and length of stay. The others were conducted using SPSS statistic. Results were present as frequencies to prove significant outcomes. This test was used for establishing significant association between variables. And then for the result, based on the frequency analysis of the data, it was found that the incident was more dominant in males. And the age range for the most occurrence was adolescent to young adults. Most patients can undergo ILS surgery in less than 24 hours. The most common cause of trauma is blunt trauma, with the most incident being motor vehicle accidents, followed by incident at home and at work. Then the most common region for patient arriving at RAD is on the medial side of the eyelid with a full thickness grade. For the duration of the postoperative evaluation, most of them only take 1 day, and the average length of patient care is within 4 to 10 days. In this variable, there is no significant relationship between the location of the eyelid and gender, as well as between the laceration region and the cause of the trauma. In this table, there is significant relationship, which is P less than 0.05 between the grade of the laceration with region of the laceration and length of evaluation of the patient. Then, of the variable length of stay, there is no significant relationship between other variables. For the discussion, the research showed greater prevalence of eyelid laceration in male patients, which is 74.2%, most of whom work in factories, workshops, or had many activities at home. This may be because men tend to work in jobs that carry a higher level of risk, and they also engage in risky behavior, such as driving without proper protection and engaging in physically demanding sport. Most of patients who underwent surgery are in active age, which is 16 to 50 years old. This is completely consistent with past findings that show ocular damage to be more common in kids, young adults, and men, and even to occur more in unskilled occupation. For more than 10 years, children, adolescents, and young adults have continued to be a high-risk demographic. The American Academy of Pediatrics and American Academy of Ophthalmology released a policy statement in 2004 that encouraged the use of protective eyewear in sports where there is a risk of eye injury. In early studies, which indicate that the workplace was the most frequent site of trauma. The study's findings show that the road, home, and workplace were the three locations where accidents happen most frequently. This could be the result of disregarding or disobeying traffic law. The government authorities need to create stricter traffic laws and greater awareness campaign. Use of safety eyewear can lessen workplace trauma. For the conclusion, men tend to have a higher incidence rate than women. The highest age range is among adolescents and young adults. The highest trauma incidents occur on the road, followed at home and at work. There's a significant relationship between the laceration grade and the laceration region, as well as between the laceration grade and the length of evaluation. However, so far, there has been no supporting data for previous study for this relation. Thank you for your attention, input and guidance. It's welcome, Doctor. Thank you very much.
Thank you for the presentation, Doctor. Any question for you? What is the recommendation are proposed based on the result of the study to prevent eyelid laceration?
Thank you, Doctor, for the question. So, what we need to what can I give for the recommendation for from this data? So, based on this data, most of the patients who get laceration on the palpebra, most of them is male and from the motor vehicle accident. So I think I think we can give a recommendation to government or the police policy of the government. So we have make a rule to make a safety guidance to make to avoid the laceration or trauma of the orbital, such as using helmet or the using helmet with a standard. Maybe we can evaluation standard of the helmet. Is there the standard is have make people safer or not? And I think another recommendation is maybe from the workplace we can give a recommendation about the safety from the worker, so the worker can have prevention to avoid trauma to the orbital. Maybe that.
Thank you for the answer, Doctor. Next presentation with code in noise free paper GR9, please.
Good afternoon. My name is Amalia Dwi Ariska. This time, I will present a study about overview of ocular toxoplasmosis in Dr. Karyadi Hospital Semarang, a 5-year retrospective study. Ocular toxoplasmosis is a common infection that causes retinochoroiditis, which is responsible for 25% blindness in developing countries. Due to the limited data on the incidence of ocular toxoplasmosis in Indonesia, we conduct this study to find out about the clinical features, medication, and complication of ocular toxoplasmosis. This is a retrospective study of 123 patients with ocular toxoplasmosis in Dr. Karyadi Hospital Semarang. Inclusion criteria were all ocular toxoplasmosis patients in a clinic from January 2018 to December 2022. Exclusion criteria were patients with inconsistency between ICD-10 diagnosis and medical record, patients who had incomplete medical records, and loss of follow-up. Ocular toxoplasmosis is an infection of the Toxoplasma gondii parasite in the eye, which is typically presents with white creamy retinal lesion and confirmed with a positive serological test. These are the data that we collected from medical record. In this study, there were 160 patients, 37 were excluded, and 123 were included. As a result, we found that the predominant age was 26 until 45 years old men, and acquired is greater than congenital. There was improvement of visual acuity after final follow-up. Posterior uveitis, characterized by retinal exudate on the posterior pole, is in the most clinical sign. Recurrences are common in older patients aged between 46 until 65 years old. Mostly patients were treated with trimethoprim sulfamethoxazole alone in combination of antitoxoplasmosis and corticosteroid. We found that ocular toxoplasmosis more commonly occurred in men at productive age, which is similar with the previous study. This is because men in productive age work more outside from home, so they have a higher risk of being infected. Sophia et al. Was stated that ocular toxoplasmosis more commonly occurred unilateral. This is in accordance with the study that found in 65% cases. We observed that the common visual acuity of patients at the initial presentation was less than 6/18 until 6/60, and the final follow-up increased to greater or equal to 6/18, and this is in line with the previous study. Visual acuity is dependent on the presence of inflammation, macular lesion, and the development of complication. Manifestation in this study is mostly primary infection of posterior uveitis with posterior pole lesion. This is similar to the prior research, which found that 77.4% of patients have retinochoroiditis. It's due to the high degree of affinity toxoplasma on endothelial cell microvascular in retina, choroidal, and retinal membranes. In this study, the prevalence of ocular toxoplasmosis was more common in immunocompetent patients. Meanwhile, in Huang et al. Study, it is more frequent in immunocompetent. This is because toxoplasma cases in immunocompetent individuals remain inactive within or near the retinal scar for long period. Recurrent infection in this study mostly occurred in elderly age. This is in line with Aruda study in 2021, which showed that older age were associated with recurrences. This research shows that mostly patients were treated with trimethoprim sulfamethoxazole and corticosteroid as an adjuvant. That medication is widely used as an alternative treatment due to low price, availability, and similar action compared to the classic treatment, which are pyrimethamine and sulfadiazine, with no significant differences. Corticosteroid had been given to reduce the duration and severity of the inflammation. Complications that mostly found in this study were complicated cataract due to the course of the disease. This study has several limitations. First, some patients had been treated by internists, such as in HIV patients, so that the policy in providing therapy is not uniform. Second, there is a potential confounding effect of previous medication before they are referred to us. We recommend that this study can be continued with additional parameters such as the duration of medication in order to learn about the long-term effects of therapy. At this time, we cannot perform PCR examination with small amount of ocular sample. In the future, we hope that it can become a research parameter and give more insight to establishing the diagnosis. We can conclude that in Dr. Karyadi Hospital, ocular toxoplasmosis was mostly found in immunocompetent male, unilateral, and with the posterior population. Recurrent infection mostly occurred in the elderly age. Acute response was found by trimethoprim sulfamethoxazole and corticosteroid medication. After all, this is the end of my presentation. Thank you for your attention.
Thank you, Doctor, for the presentation. Next, any question for you? Are there any supporting journals discuss the relationship between male gender and unilateral toxoplasmosis? Can you explain for me?
Thank you, Doctor, for the question. In my study, the male immunocompetent patient is greater to have risk factor for ocular toxoplasmosis. This is because the previous journal conclude that male in productive age in this study is 25 until 46 years old male is work more outside from home, less than the female in productive age. And then, so they have a higher risk of being infected of ocular toxoplasmosis, doctor. And the male of habit of the hygienity of the male is worse than the others. Thank you.
Doctor, thank you for the answer, Doctor. Next presentation, you please the presentation with the code in our post free paper GR1.
Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Anditya Sidotomo, and I would like to present my pre-paper about the relationship between characteristics and underlying eye disorders with optical aid selection and visual acuity status differences in children with low vision before and after optical aid selection. Low vision is a disorder with a significant impact on a person's independence, especially children. Visual loss is less common in children, however, visual impairment can be treated. From the data by WHO in 2019, there are 246 million people with low vision, while in the United States, 9% of low vision population are children. Visual impairment data in the pediatric population is limited and reflects the underestimation of children with low vision. Children with low vision is irreversible vision loss or permanent visual impairment from children younger than 18 years, which can be corrected by refractive correction, medical therapy, or surgery. Eye disorders underlying low vision classify anatomically based on the diagnosis, while visual acuity status stays as the main parameter of visual function in low vision evaluation. The purpose of this study is to learn more about the relationship between characteristics and underlying eye disorders with optical aid selection, as well as differences in visual acuity status in children with low vision before and after optical aid selection. Methods. This is an analytic observational study with a cross-sectional design using secondary data of medical records of all children with low vision visiting for the first time on January 1st, 2018 until December 31st, 2020. Inclusion criteria between the ages of 4 and 17 years old that have medical records that are accessible and comprehensive. Exclusion criteria include visual acuity better than or equal to 20/60 and visual acuity worse than 20/1000. Descriptive, we are using sums and percentage in tables, while bivariate, we are using chi-square, and for visual acuity status differences, we are using Wilcoxon test. From the optical aid selection, the glasses was provided to the entire sample. We can conclude that the primary eye surfaces can help many of these children, even without special low vision surfaces. While magnifier prescribed much more than the telescope, conclude that the children have a greater need for close-up visual activities, while long-distance visual needs can still be met with glasses. From the characteristic, we found no significant relation between characteristic and optical aid selection. It's the same with the result by lab that state that gender and age was not significantly related, while Becker stated while age is not an indicator of low vision aid use, but women are more likely to use assistive technology. While Coltrane stated that low education is not a contributing factor, Illichi stated that almost half of this condition can be prevented by surgery. There are three most common underlying eye disorders. The first is retinal abnormalities, with the same as the study by Kavita. The second is the lens abnormalities, with the same study by Gao. And the third is refractive error, the same result as the Atoa and Pilangalanga. However, we found no significant association, same as the result by Demerkley. From the visual acuity status differences, we found before an optical aid, after it, there were severe VI as the largest proportion, while result by Shah state that before optical aid selection, profound VI was the largest. However, after optical aid selection, the highest was moderate visual impairment. We found that there is at least 0.1 logMAR differences in all samples, and the largest is 0.1 logMAR with 46 children. While the result by Sanes and Anand stated the highest increase in visual acuity was 2 lines or more, while the remaining 80% of children don't have a visual acuity increase. Altinbein and Adibali also state that the largest proportion with visual impairments had a visual acuity increase of at least 0.2 logMAR. A significant difference between visual acuity before and after optical aid was found with a minimum increase of 0.1 logMAR in all samples. It's similar with the result by Kavita that state that most children, 80%, experience an increase in visual acuity after the optical aid selection. Study limitation, uneven sample distribution, and a relatively small sample size, and the data only come from the data listed in medical records. The conclusion, there is no relationship between characteristic and underlying eye disorders with the topical aid selection, while the significant difference was found between visual acuity before and after optical aid selection, with a decrease in logMAR at least equal to or greater than 0.1, which means increase in visual acuity of all 72 children with low vision. Thus, optical aid selection necessary for children with low vision. Thank you and have a nice day.
Thank you for the presentation, Dr. Adityo. Adityo, next, any question for you? What if CDVA result after a month becomes worse? What should be need to be assessed?
Thank you for the question, Doctor. From my result, we only look for the best corrected visual acuity after correction, but we have a limitation because there are some people that doesn't follow up even after given a low vision aid optical correction. So there are some patients that we have the data for 1 month or 2 months or so, but there are many patients that we don't have the data. So we if we see from our study result, only less than half that have corrected visual acuity stated in the medical records. So we recommend for the next clinical research to have a prospective result where we follow the patient a month or so or 3 months after using the optical age selection, and also evaluate another visual acuity function such as near and long distance vision, or such as like reading capabilities of those patients, so that in the future we can clearly see and determine which patient will likely use the optical device based on their capabilities. So that's maybe our recommendation. Thank you.
Thank you for the answer. Next, the presentation for with code in a CHRS free paper GR25.
Good afternoon to all panelists. Thank you for the opportunity to present my study with the title Outcomes Comparison After Small Incision Lenticle Extraction SMILE and Femtosecond Laser Assisted In Situ Keratomiliosis FS LASIK in Low Moderate Myopia Patients. For disclosure, I have no financial interest related to this study. As introduction, myopia is the leading cause of visual impairment in the world, with increasing global prevalence and estimated to reach almost half of the world's population in 2050. It will potentially cause significant global impacts as well to Indonesia. Myopia can be treated by refractive surgery. SMILE is less invasive than FS LASIK due to flapless and all-in-one femtolaser procedure. The SMILE incision is much smaller than FS LASIK flap, which results in less inflammation, fewer corneal fibers disruption, and better corneal biomechanics. Several existing studies were done without specific grouping of myopia degrees. The correction for low-moderate myopia needs special concern, because the pre-op vision is usually still quite good, so even a slight reduction may be noticed by the patient and affect satisfaction. To date, there is still no such study in Indonesia. The purpose of this study is to compare the refractive outcomes between SMILE and FS LASIK in low-moderate myopia patients. This was a prospective analytical observational study conducted in Cicendo Eye Hospital, Bandung in 2022 after obtaining ethics committee approval. The inclusion criteria were eligible patients with spherical equivalent between -0.5 to -6 diopters, cylindrical powers less than 1.5 diopters, and other routine requirements. The exclusion criteria were any corneal pathology, complications, and not coming patients. The visual acuity examination was performed using ETDRS chart with logMAR notation at pre-op 1 day, 1 week, and 1 month. The platform used for SMILE was Visumax from Carl Zeiss, and for FS LASIK was VisX Star S4 from Abbott Medical Optics. For refractive parameters, predictability, efficacy, safety, and stability were assessed at 1 month, and we used chi-square test for the statistical analysis. For the results, there were 22 eyes from 12 patients in SMILE group and 20 eyes from 12 patients in FS LASIK group. There were more male subjects and most having bilateral procedure. All demographic and clinical characteristics between both groups were not statistically different pre-operatively. At 1 month follow-up, the post-op SE was -0.09 diopters in SMILE and -0.38 diopters in FS LASIK. The difference was significant, while the post-op UDVA and CDVA were not significant different. Figure 1 showed the predictability chart. It described how close post-op SE to 0 diopter. The eyes within ±0.5 diopter, or the yellow one here, were 95.5% in SMILE and 80% in FS LASIK. It was more in SMILE group, but not significant. Figure 2 was the efficacy chart. The blue bars show the post-op UDVA. The eyes with post-op UDVA over 2020 were 64% in SMILE and 35% in FS LASIK. It also more in SMILE group, but not statistically significant. Figure 3 showed the safety chart. No eyes from both groups with BCDVA loss with p-value equal to 1. Figure 4 was the stability chart, showing SE timeline from pre-op until 1 month. The eyes with SE changes more than 1/2 diopter were 4.5% in SMILE and 5% in FS LASIK, with p-value equal to 1. For discussion, in case predictability, there were more eyes in SMILE with post-op SE closer to 0 diopter. These results were similar with other studies, who also reported better SE for SMILE at various times. Predictability describes how accurate the laser can modify corneal stroma to achieve refractive target. One affecting factor was corneal hydration status. This occurred mainly in FS LASIK, where the stroma was exposed to outer environment, while in SMILE it was flapless and not exposed. Efficacy meant the mean event after surgery by very good vision without spectacles help. FS LASIK relatively gave a wow effect at quick and excellent UDVA at 1 day post-op, while SMILE has slower visual recovery in early post-op. This might be caused by these corneal conditions, but it's only transient and the SMILE UDVA was gradually improved over time. At 1 month, there were more eyes in SMILE that reached UDVA over 2020 than FS LASIK. A procedure is considered safe if the post-op CDVA was not worse than pre-op. No eyes from both groups with CDVA loss, that consistent with this review reporting only 0 to 2% CDVA loss. Stability is related to corneal biomechanics. Meta-analysis studies showed better preservation in SMILE. This is mainly due to the fundamental difference between the flap-forming FS LASIK than the flapless SMILE. In this study, there was no much difference at 1 month. However, it cannot be generalized yet, because other studies reported better stability favoring SMILE in longer period, as seen below. The limitation of this study was the short follow-up time of 1 month. We suggested further studies with longer follow-up, especially to observe the stability for at least 3 months. The strength of this study, we used ETDR start with Lockmar notation that could sensitively detect even small differences in visual acuity better. This study also already included 4 main refractive parameters that follow the standardized recommendation for reporting refractive surgery papers, which is useful for uniform interpretation and comparisons. At conclusion, both SMILES and FS LASIK could be recommended for low-moderate myopia correction. SMILE had better predictability and efficacy compared to FS LASIK, although not statistically significant. Both procedures had the same safety and stability at 1 month post-operatively. Thank you for your kind attention.
Okay, thank you for the presentation, Doctor. And next, any question for you? How to minimize the bias of this study?
Thank you, Doctor, for your question. So to minimize the bias from my study, first, I have to obtain the quite same amount of patients in number and also in their characteristic. In my study here, I have quite same amount for the patient who conducted SMILE and LASIK, and also from their refractive error, I limit the refractive error, which categorized as low to moderate myopia, which is they have spherical equivalent below 9 diopter, 6 diopter, sorry. And also I limit the cylindrical power less than 1.5 diopter, because as we know that there were 2 components from the cylindrical power, that is power and also axis to be corrected. So I also limit the cylindrical power here below the 1.5 diopter to minimize the bias. Because the cylindrical power need to be corrected with more consideration. I think that's all. Thank you, Doctor.
Okay, thank you for the answer. Next, a very nice all presentation. Thank you for all participants. It's the end of our session. Thank you for Dr. Kamala Sayuti and committee and all participants. Thank you for participant. We come back to committee. Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon,
Salam.
Dr. Muhammad Soki dan dokter-dokter. This session we have 6 presentation. Please the number 1 session, Dr. Linda.
Assalamualaikum warahmatullahi wabarakatuh. My name is Yulinda and I'll be presenting our paper titled Axial Length Elongation of Children with Myopia on 0.01% atropine. As we all know, there's been an increased prevalence of myopia. The risk arising from high myopia has further increased and it may impact their qualities of life. So interventions to slow down progression have been studied, one of which is the atropine eye drop. Atropine is a non-specific muscarinic acetylcholine receptor antagonist. Studies on its effect on axial length, however, has shown various results, and there's also been lacking studies in Indonesia. So the aim of this study is to evaluate the effect of 0.01% atropine eye drops, specifically on AL elongation in an Indonesian eye clinic setting. It is a retrospective child review of those children with myopia who commenced 0.01% atropine therapy at Cayman Eye Care Jakarta, Indonesia, in 2020 until 2021. All of these myopic children commencing 0.01% atropine at Cayman Eye Care in 2020 to 2021 are included. Those meeting the exclusion criteria are excluded, including those who are lost to follow-up, since we have a follow-up minimum of 6 months. Data being extracted include age, gender, refractive error, axial length, and reports of adverse effects. Refractive error is measured at baseline using cyclopedia, and the follow-up is using manifest or cyclopedic refraction. They're all converted into spherical equivalent. Axial length is measured with optical pyometry. Indication of therapy is an increase of myopia of more than 0.5 diopters a year. So 0.01% atropine is instilled 1 drop each night on these children, and it is obtained by using the dilution method done at our pharmacy. Quantitative variables are reported as mean or median according to the normality of data. Association of myopic progression in terms of AL changes and SE changes is studied through Wilcoxon sign rank test. Multivariate linear regression analysis is done to see potential confounding factors. Data is managed using Excel and analyzed using SPSS version 26. So this is the result. There's 41 number of subjects in which the median age was 9 years old. There's a little higher number of female compared to male. Follow-up median was 12 months. This is the ocular parameter before and after atropine therapy, in which there's a total number of 82 eyes. There was still a significant increase of axial length and spherical equivalent from baseline to follow-up. The delta axial length was 0.32 millimeters, while this delta spherical equivalent was minus 0.44 diopters. So from this number, we can see that this is already lower than our indication of therapy. Multivariate analysis of AL elongation was studied to see its association versus baseline SE, baseline AL, and age. These 3 did not show any significant association, while obviously there was an association of AL elongation versus delta SE, in which there's a decrease of 0.31 millimeters of elongation for every decrease of 1 diopter myopia. There are no reports of side effects. So atropine is considered to stimulate growth inhibiting signal for the eye. High concentrations of 0.5 and 1% are effective in slowing down progression. However, it has undesirable side effects. So lower concentrations are used to gain its beneficial effects with lower risk of adverse reactions. What about atropine on axial elongation? Long axial length contribute to vision threatening complications. However, there's different conclusions arising from its studies. Some say that there's that 0.01% atropine has greater impact on SE rather than AL, meaning that there's still rapid elongation found despite therapy, while other studies see a significant inhibitor effect of 0.01% atropine on axial elongation. In this study, there's an elongation of 0.32 millimeters over a median of 1 year. This number is quite a little lower than the LAMP and the FEW et al. study. There are still limitations to this study as it is retrospective with no control. Therefore, there is still unknown significance of halting progression compared to without treatment. And cycloplegic refraction was not regularly done during the follow-up visits. There was a variety of follow-up timing, and we need a longer period to see the long-term efficacy. So in conclusion, atropine in the concentration of 0.01% in this study slows progression in terms of AL elongation similar to previous studies. It may reduce the risk of complications arising from long AL. However, comparison to elongation in untreated patients to know its clinical significance is unknown. These are the references. Thank you very much for your attention.
Dr. Linda, what are your suggestions for supporting this research in the future?
So the limitation to this study, it is one of the big limitations that it's a retrospective study with no control. So therefore, if you want to see the how much effect the atropine of 0.01% has on SL length, it would be a much better. It would be much better if we study it prospectively, and therefore also with a control. So the ideally we would have an RCT. So again, a prospective study with a control. So we know that we can compare between treated and untreated patients, and also it would be better if we have a uniform duration of follow-up. One of the limitations to this study is that since it is a retrospective, even though most of them have a follow-up period of 1 year, there were also patients that had the follow-up period of less than a year or even more than a year. So a uniform period of treatment would be better. And also it would be also better to have a cycloplegic refraction for all the patients and also during the follow-up. Thank you very much.
Thank you, Dr. Linda, for your presentation.
Thank you.
The next time for Dr. Yuri.
Hello everyone, my name is Yuri Dwi Mahesari. I would like to present my study entitled Agreement of Parametric Method Rapid Fields Parameters to Humphrey Field Analyzer in Patients with Moderate to Severe Glaucoma. Relationship between visual acuity and accuracy of Mabry rapid fields. As introduction, in glaucoma sufferer, the most impaired visual function is the visual field. SAP is currently the gold standard tools to assess visual field defect in glaucoma such as HFA. However, HFA has some limitations. The first is its size. It is a large machine and it is not easily portable. Second, examination using this device needs a certain precision and certain height, so it will be difficult for patients who cannot still sit in a long period. Besides that, the price is also quite expensive. COVID-19 brings big problem for health services, including ophthalmology, but it is also a good catalyst for accelerating new technologies in health services. MRF is one of those technologies. It is a new opportunities for remote or telemedicine visual field testing. However, MRF study is still limited. MRF study has not available yet in Indonesian subject and no study in poor visual acuity subjects. So the present study aimed to assess the correlation and agreement between MRF and HFA outcomes in moderate to severe glaucoma patients in good visual acuity and impaired visual acuity. Present study design is cross-sectional observational study. The study period is 3 months. The study was done in Glaucoma Clinic Cipto Mangunkusumo General Hospital, Jakarta, and the participants are moderate to severe glaucoma patients with good and impaired visual acuity. These are the inclusion and exclusion criteria. We move to result and discussion. From the demographic and clinical characteristic, we found gender in the present study has the same result with prior study. In the subject's age, elderly as a risk factor for glaucoma dominating the subjects. POAG is the most common glaucoma type included in the study. And present study included moderate to severe glaucoma only. It was dominated by severe glaucoma, about 81%. Test duration results showed MRF has shorter test duration than HFA in all subjects, similar to previous studies in Australia and India. The reason is the differences in the retinal sensitivity measurement methods, MRF using Bayesian methods, while HFA using pointwise. The reliability index, including physician loss, false positive and false negative that can be measured in both perimetries. The results showed there is no significant differences between the perimetries in the fixation loss variable, similar to prior study by Kumar. However, it differed to study by Gong. Only 29 eyes that was analyzed using Wilcoxon test, about 55% cannot be analyzed due to undetected blind spot. False positive and false negative results showed no significant differences between MRF and HFA. There are about 33% eyes that false negative result cannot be analyzed because it cannot be assessed in HFA. The reason may be because of the difference in the measurement method that false negative is the same as the differences in the retinal sensitivity measurement. Mean defect variable was assessed for the correlation and agreement. The results showed very strong correlation and very good agreement between MRF and HFA, consistent to prior studies using doublet-based MRF. These excellent results can be achieved in clinical study and in experienced subjects in HFA examination. However, 64% eyes have MD more positive on MRF than HFA. It can lead to underestimation of visual field defect. The same as mean defect, visual field index or visual capacity also showed a very strong correlation and very good agreement between MRF and HFA. However, 69% eyes have VC more than HFA. Test retest MD on MRF showed very strong correlation and very good agreement. Very strong correlation can be assumed that reproducibility of MRF is very good. Then very good agreement can be interpreted as the learning effect is almost none in experienced subjects in HFA examination. As good as test retest for MD, VC on MRF also showed very strong correlation and very good agreement. MRF accuracy was measured using RMSE. RMSE is root mean square error. Is used to assess the differences between point-to-point retinal sensitivity in MRF that reproduces to each subject. We found no correlation between visual acuity and RMSE, and there is no significant differences on RMSE between group 1 and 2. However, there is no prior study that evaluated MRF accuracy between good and impaired visual acuity. Correlation between visual acuity and MD on MRF and HFA showed a weak strength negative correlation. This is the scatter plot. Showed negative correlation between visual acuity and MD on MRF and HFA. It can be interpreted as a smaller logmark correlate to more positive MD or better visual acuity correlate to smaller visual field defects. So in the present study, we can conclude that shorter duration on MRF than HFA in both groups, no significant differences on reliability index between MRF and HFA in both groups, strong correlation and very good agreement on MD and VFI or VC between MRF and HFA in both groups, very good test retest MD and VC on MRF in both groups, and no correlation between visual acuity and MRF accuracy in both groups. That's all, and thank you for your attention.
How to avoid bias in this study?
Yes, thank you for the questions. Okay, I will try to answer. In this study, we include the patient with good visual acuity and poor or impaired visual acuity. So in this kind of study, we present to reduce the bias by using consecutive sampling methods, and when we the order of the examination between HFA and MRF using block randomization, so it will be minimize the bias between HFA, and after doing HFA examination there will be fatigue result or fatigue effect on the patient when did the MRF examination, and in the opposite, maybe when a patient has to do examination with MRF, and after that doing HFA, there is no fatigue effect. So we minimize this kind of bias using randomization, block randomization. So the order will be similar between group 1 and group 2 and each patients. Thank you.
Thank you. Great presentation. The next session, please, Dr. Wildan.
Good morning, professors, doctors, and colleagues. My name is William Matsatoso. Today, I will present my research about the impact of capsular tension ring on visual outcomes in cataract patients with weak zonules undergoing phacoemulsification, a systematic review. Before I jump to zonal weakness, I will explain what is zonule of Zinn, which is a suspensory ligaments that connects the body and capsule of the lens. Its function is to stabilize the lens position and contributed in lens accommodation. Zonal weakness is characterized by laxity in the zonal fibers connecting to the ciliary body to the lens. The predisposing factors are history of post-planar vitrectomy, pseudoexfoliation syndrome, high myopia, etc. Zonal weakness poses considerable challenges in phacoemulsification surgeries performed on cataract patients because it may cause risk of complications such as capsular rupture, vitreous prolapse, and IOL malposition. Capsular tension ring is a supportive device that can compensate weakened zonule by stabilizing the lens. This device can reduce the risk of IOL dislocation during or after cataract surgery by maintaining the shape of capsular bag, balancing tensions on zonal fibers, and decreasing the risk of capsular shrinkage and IOL dislocation. On the other hand, the CTR often requires compression or implantation, which can potentially cause additional damage to the zonule. This consideration highlights the need for further investigation. Therefore, the aim of the study is to compare outcomes in cataract patients with zonal weakness who underwent phacoemulsification with and without CTR. We use the search strategy and the keywords and for databases. Our inclusion criteria include a minimum follow-up period of 1 month in zonal weakness eyes undergoing phacoemulsification, published between 2013 and 2023. The outcomes are UCVA, BCVA, IOP, lens malposition, and complications that we are measured. We use confidence to assist our systematic review. We use Prisma 2020 flow diagram, and from the 57 studies initially selected, we got 1 RCT and 2 retrospective cohorts. 228 patients and 240 eyes were collected in our studies. Females with zonal weakness are more than males. The most common etiology of zonal weakness in our study is pseudoexfoliation syndrome, followed up by high myopia, PPV, etc. Young studies has comparable total population number in both groups, while Miyoshi et al. Does not, and Singleton does not. The minimum period of follow-up in our study is 3 months. In terms of visual outcomes, we found that the use of CTR showed better UCVA and BCVA in these 3 studies, although it was not statistically significant in young studies. In Miyoshi, the use of toric IOL using CTR showed significantly better UCVA and BCVA. This aligns with Rika et al., who also reported CTR use suggested improved early and medium-term post-operative BCVA. We found that IOL tilt degree was significantly lower in eyes with CTR, as seen in the yellow box. This is similar with previous findings from 4 studies. CTR lower IOL concentration in eyes with toric IOL, but not in multifocal IOL. Miyoshi et al. Indicated that this is probably because patients with pseudoexfoliation syndrome and phacodenesis are contraindicated in using multifocal IOL. The area of continuous curvilinear capsular axis, or CCC, was observed in young studies. We found that the area was more stable in CTR group after 3 months of follow-up. This indicates that CTR application may assist in stabilization of ICCC and reduce the risk of capsular shrinkage in earlier period of time. Capsular contraction syndrome was a complication found more frequently on the non-CTR group, coming from myopia cases. Therefore, the use CTR can reduce the occurrence of capsular shrinkage and contraction, particularly in patients with severe myopia. Singleton observed a higher percentage of complication in CTR group in patients with pseudoexfoliation syndrome. However, the study was conducted with differing sample size in both groups. There is also possibility of progressive zonal decline over a longer period of time that may not entirely be prevented by CTR placement, as one as previous studies that reported significant IOL dislocation in the range of 2.5 to 8 years after implantation. The limitations are limited studies about zonal weakness, that we only got 3 studies, and of that there was only 1 RCT to include, and a short follow-up period of studies. We suggest future studies to have more RCT about this topic, place greater emphasis on longer-term follow-up of lens position in relation of visual outcomes, and develop guideline of grading zonal weakness to aid in determining the necessity of utilizing CTR and formulating better prognosis. In conclusion, the visual acuity outcomes are similar for cataract patients with weak zonules who undergo phaco investigation with or without CTR. Nevertheless, CTR implantation help reduce the extent of lens alignment. The significance of our study is that understanding CTR application in weak zonule patient may give better strategy on management of cataract in weak zonules. This is our references, and I would like to acknowledge my colleagues who are contributed in my studies. Thank you. I'm sorry, doctor.
Yes. What is the prognosis for visual acuity in phaco surgery using CTR? Why?
The prognosis is good. I mean, it's bonum because the CTR helps to maintain the stabilization of the lens. In our study, the population is patient with weaker zonule, but in short period of term, like in our study, like 3 months until 6 months, the prognosis is good because we found that it stabilized the lens position, and we found that statistically significant in lens position, but the visual acuity is almost the same with CTR and without CTR. But we cannot say that in longer period like 1 year or 2 years, the prognosis is good because we found that in previous study, the longer period, there are some patients that cannot, the lens is not stabilized after using CTR. That's why we need longer, more RCT, especially a longer period of study for CTR treatment for cataract with phacoemulsification.
Thank you for your presentation.
Thank
the
you.
next session, Dr. Putu Ayu, please.
To the honorable professors, doctors, judges of the 48th PET PERDAMI scientific competition, please allow me to introduce myself. My name is Ayu Wulansari, and today I'm going to present my observational research titled Clinical Correlation of CD4 Count and Dry Eye Disease Severity Among HIV Patients. As we all know, dry eye is one of the most common ocular conditions encountered in daily practice and is associated with varying degree of ocular discomfort symptoms and ocular morbidities. This explains why the research on the field of DED is still vastly growing up until now. This time I'm going to talk about DED, which has been reported as one of the most frequent anterior segment ocular manifestations in HIV patients, and my research aimed to investigate the correlation between CD4 count and the severity of the DED itself. So this was a hospital-based cross-sectional study where 75 HIV patients were referred to an in-house ophthalmology clinic located inside the visitor clinic for ocular-related complaints. And here are the complete inclusion and exclusion criteria for the study. Primary data was taken through interviews. Secondary data was from medical records. Ocular examinations, including OSD score and GBUT results, were recorded. And here are the results of the study. In Table 1, we can see the socio-demographic and clinical characteristics of the study, where it was dominated by male in age group of 30 up to 39 years, working and had proper educational background. All patients were already on antiretroviral therapy with varying lengths of treatment and clinical stage. However, most of them developed co-infections with mean CD4 is 244 cells. Table 2 shows distribution of DED severity across different variables, and as we can see here, CD4 count is statistically significant with P is 0.005.
More on that, CD4 count also significantly correlated with TB result with moderate positive correlation and negatively correlated with OSD score. So these two graphs further confirms the correlation between those variables where low CD4 count correlates with low TB results and higher OSD scores, thus correlates with increased severity of the dry eye disease. And based on the ANOVA result, it was further analyzed in post-hoc tests using Bonferroni approach, and it was found that there was a significant difference in CD4 count of patients showing mild dry eye symptoms compared to severe ones. So the result of this study has been supported by some previous studies alike. For example, GODA in 2015 highlighted decreased aqueous layer in patients with low CD4 count, as seen by the Schirmer, Tribute, and Rose-Bengal test. Matebula also found lower Tribute and Schirmer result compared to healthy controls, and there was a significant correlation between dry eye and CD4 that is less than 200. Nguyen, on the other hand, recently in 2020 emphasized the possibility of meibomian gland damage in the form of meibomian gland dropout, which is negatively correlated with CD4 count, meaning the lower the CD4 count, the higher the probability to get meibomian damage. So the mechanism of dry eye in HIV patient is initially hypothesized to be due to the infiltration of the HIV virus into the lacrimal function unit, where this was evidenced by the discovery of HIV RNA in tears of patients with low CD4 count but not in the high ones. So usually under normal circumstances, they're supposed to be extremely tight cell junctions. However, HIV can produce a specific TAT protein that could increase BRB permeability, enabling the virus to get into the eye, replicate, and further infiltrate the lacrimal function unit, where this was mediated by lymphocytes, macrophages, dendritic cells, and also CD4 T cells. So this is the reason why the infiltration by the HIV to the LFU can only happen in the setting of the low CD4 count. This is the limitation of the study. And as for the conclusion, so there is a correlation between CD4 count and dry eye disease. The lower the CD4, the higher the risk for the HIV patients to get severe dry eye. So this shows the importance of CD4 control and monitoring to prevent ocular disease and manifestations related to HIV. Well, I think that is all from me today. Thank you very much for your kind attention.
Please, Dr. Soki.
Okay, thank you, Dr. Kamala. My question is, in this study, you use two examination, OSD questionnaire and tear breakup test. How do you correlate these two result examination to define the dry eye disease severity? And the next question is, dry eye pathophysiology is inflammation. If the CD4 count is low, then the immune system is weakened. What is the rationale between the CD4 level and the dry eye disease? Thank you.
Good afternoon, doctor. Thank you for the question. As for the first question, how do I correlate between the examination using the tear breakup time test and the OSD score to the classification of dry eyes? So basically, from the current practical guidelines from the INOIS, they only stated that to classify the dry eye disease severity, we only need like tear breakup time test result and also the OSD score. Schirmer is now practically maybe less preferable because it is tends to be irritating to the patient, and also for this kind of patients we kind of like opt for examinations that is usually or basically takes less time. So that's why we only use the tear breakup time result. And for the OSD score, what's missing from this research is the variable for tear breakup
for tear breakup pattern, where tear breakup pattern is also mentioned in the classification of the dry eye disease. And as for the second question, for the basic of the dry eye disease is actually inflammation. Well, actually from the previous studies, there was contradictory result. Some studies state that a low CD4 count correlates with higher severity of dry eye, but some others vice versa. So that explains on inflammation, there may be the dry eye, CD4, the high CD4 can cause a lower severity of dry eye, but in this case, the CD4, the low CD4 is correlated with higher chance of HIV infiltration. Thank you.
Yeah, thank you for the answer. Thank you, Dr. Kamala.
Thank you, Dr. Sophie. Thank you, to Ayu. The next presentation is Dr. Belinda.
Good morning, respected doctors and ophthalmologists. Hereby, I, Belinda Liliana, and my team would like to present a literature review regarding appropriateness of antibiotics prescription for conjunctivitis in primary healthcare. Conjunctivitis is inflammation of the conjunctiva. The majority case is self-limiting, but some might result in ocular and extraocular problems. It affects around 6 million individuals in the United States each year, with 2% being detected in primary healthcare. Most patients are first treated by general practitioners or GPs. The most common etiologies of conjunctivitis are viral infections and allergies, and the treatment should be based on etiology. However, obtaining a definitive diagnosis is difficult due to overlapping symptoms. Therefore, many GPs prescribe antibiotics for conjunctivitis in primary healthcare, whereas inappropriate antibiotic usage can result in adverse effects on the eye. Therefore, a literature review is needed to identify the appropriateness of antibiotics prescriptions for conjunctivitis in
Suaranya hilang ya?
Iya, di stop ya. Panitia mungkin bisa.
Izin dokter, sepertinya videonya macet.
Videonya ya, ya. Minta tolong panitia.
Good morning, respected doctors, were sorted as a reflex are diagnosed with conjunctivitis in 2 electronic databases. The appropriate antibiotic usage can result in adverse effects on the eye. Therefore, a literature review is needed to identify the appropriateness of antibiotics prescriptions for conjunctivitis in primary healthcare. The literature search was conducted using 2 electronic databases. They are PubMed and Scopus. The study inclusion criteria are journals published from 2012 until 2022 in Indonesian or English, and the subjects are diagnosed with conjunctivitis in primary healthcare, while the exclusion criteria are under 18 years old patients, inaccessible full articles, review articles, and study protocols. 443 articles were gathered, then were sorted. As a result, 8 studies were discussed in this review. Several countries have reported the prevalence of antibiotics prescriptions in conjunctivitis. In Australia, antibiotics were prescribed in 74% cases within 8 years. In Belgium, it was 89.4%. In Colombia, it was more than one-third. In the Netherlands, patients were prescribed antibiotics irrationally 53% in 2019. There were several reasons that could lead to inappropriately prescribing antibiotics for conjunctivitis. We categorize them into three main factors. First, from GP's factors include short time for consultation, difficulty to distinguish infectious etiologies, lack of confidence due to patient or pharmaceutical company pressure, less training, fear of possible complications, and desire to maintain a good patient-doctor relationship. Second, from the patient's factors are such as perception of antibiotics and dissatisfaction due to the lack of prescriptions given. Last, from the primary healthcare factor is availability of therapy guidelines and drugs. Inappropriate use of antibiotics has raised concerns about antibiotic resistance. For example, one of the common antibiotics prescribed is chloramphenicol. The most common chloramphenicol-resistant pathogen is Pseudomonas species. Besides resistance, complications and adverse reactions that might happen, such as worsening infections and increased intraocular pressure. Then, impact for social and economic aspects is such as stigma attached to the need for antibiotics in all cases and large costs. We also found that the factors that reduce the inappropriate use of antibiotics for conjunctivitis are availability of drugs on an over-the-counter basis, wait-and-see method, analysis of electronic data routinely collected, development of antibiotic prescribing guidelines that are regularly reviewed based on local resistant patterns, and training for GPs that will increase understanding regarding the consideration of prescribing antibiotics. From all that we have reviewed, prescribing antibiotics for conjunctivitis in primary healthcare is mostly inappropriate. Training for proper treatment of conjunctivitis is needed for GPs, as well as educating patients regarding conjunctivitis and antibiotics. Most studies regarding antibiotics prescriptions for conjunctivitis were held overseas. Therefore, we think that further study in Indonesia is needed. These are the references that we cited to write this literature review. That's all for our presentation. We appreciate any suggestions for our review. Hopefully, our review could increase awareness regarding appropriate antibiotic prescribing for conjunctivitis. Thank you very much.
Okay, Dr. Belinda, how do you define the inappropriate prescribing of antibiotic while you reviewing the literature? What indicator do you use so you can define this? In this article, there are inappropriate prescribing of antibiotic. Thank you.
Okay, thank you, doctor, for the question. As the authors define the inappropriate prescription of antibiotics, first, inappropriate antibiotics, as the studies we reviewed define that it is when the bacterial conjunctivitis are non-bacterial conjunctivitis are treated by antibiotics. Therefore, we know that it is inappropriate from the studies because from the diagnosis, they collected the data from the diagnosis with ICD-10, and it is such as viral conjunctivitis, allergic conjunctivitis, and so others. And in that, in conjunctivitis, other etiologies from bacteria, the GPs prescribe antibiotics. Therefore, the authors from the study we reviewed concluded that it is inappropriate to prescribe antibiotics for conjunctivitis that wasn't caused by non-bacterial, such as viral, allergic, and the others.
Okay, thank you.
Thank you, doctor.
Thank you, Belinda. The last session, the last presentation is Dr. Dewi.
Hello everyone, I'm Dewi Alia Winarto and I'm going to present a systematic review with the title of The Effectiveness of Pharmacological Therapy as the Initial Treatment for Primary Congenital Glaucoma, or PCG. It has been known that the gold standard treatment for PCG is surgery. However, not all children could receive surgery immediately, for instance, due to general anesthesia considerations. Oftentimes, IOP-lowering medications are required as an initial therapy. Currently, there are some knowledge gaps on the drug's efficacy, such as the lack of evidence, particularly on naive PCG patients. Secondly, the already available older studies showed poor response towards some drugs. Thus, this review aims to discover the effectiveness of various anti-glaucoma drugs in controlling IOP prior to surgery in PCG patients. There were 179 studies collected from 4 databases. After being screened and assessed based on the following criteria, there are 2 studies included. The first one is by Ufa et al., a retrospective cohort study from 2014. The second one is by Dixon et al., an RCT from 2017. First one is a single-center study, while the second one is a multi-center study involving both developed and developing countries. They both used similar criteria for effectiveness, which is an IOP reduction of equal to or more than 15%. For the RCT, they also test for non-inferiority using an upper margin of +3. The drugs assessed were latanoprost, travoprost, and timolol. There were 44 naive PCG patients with a total of 81 eyes. On the other one, there were 22 patients in the travoprost group and 23 in the timolol group. The mean age between the 2 studies varied greatly, since the second study decided to combine the analysis for both PCG and non-PCG. They claimed that there were no statistically significant differences in their baseline demographic. And these are the follow-up times. From the table, we can see that all drugs were able to decrease the IOP for more than 20%, and thus they are effective. Looking at the amount of changes, it is greater in latanoprost than in the other 2 drugs. In the cohort study, after 18 months, latanoprost yielded a change of 8 mm mercury, which is actually comparable to that in older children and adults. In the trial, the amount of change are rather small. In fact, they failed to reduce the IOP of 6 patients, and this might be attributable to their very high IOPs in the beginning of the study. Theirs were above 31 mm mercury. It seems like a more severe condition will not gain as much decline. Another interesting finding is that travoprost is non-inferior to timolol. Unfortunately, the superiority cannot be determined since the confidence interval did not lie entirely below 0. On the other hand, the response rate was actually better in travoprost and timolol. They're above 50% when compared to latanoprost, which was only less than 30%. No serious adverse events were reported from the use of latanoprost and travoprost, yet there was one patient who experienced dizziness and ended up discontinuing the treatment. Okay. Despite the small number of studies being reviewed and the small number of PCG patients in the RCT, we include one of the first long-term study on drug efficacy in children. This review could also have a high generalizability with the inclusion of a multi-center study. In conclusion, latanoprost, travoprost, and timolol are all effective and have no alarming safety concerns, except for timolol. They might be the most beneficial for patients with mild to moderate severity, with its potential role as a primary therapy and in delaying surgery. In most cases, surgery is inevitable, hence routine IOP control is mandatory. Future studies with a better level of evidence and larger sample size are needed. Thank you.
Okay, Dr. Dewi, my question is, in this review, you use only 2 articles. In the core study, the result is 70% of patients had not control with the medication. On the other hand, in the trial, 60% had control with the medication. Can you explain why these two studies had contradictory result? And why in the conclusion you still conclude that this drug had a potential to as a primary therapy or to delay the surgery, because the previous study result is still inconclusive. Thank you.
Okay, thank you, Doc, for the question. So for the first question, the second study, which is the trial, seems to have a higher number of responders. This may be attributable to their analysis method. So they combine the analysis for both the PCG and non-PCG patients, in which the non-PCG patient, most of them have juvenile open-angle glaucoma, and thus the participants tend to be older, and they seem to respond to the treatment better than the younger age group, which mostly have PCG as their condition. And then, sorry, for the second question is, can you see?
In the conclusion, you mentioned that
Okay.
this drug has a potential. Yeah.
Okay, so actually, that point is for the first drug, which is latanoprost. From the first study by Ufa et al., latanoprost was given for a mean duration of 18 months. So that was a pretty long duration for the treatment. And some of them was able to avoid surgery or delay surgery up until that time. So until 18 months, their IOP can be controlled without surgeries. So that's why I suggest that this drug, especially the latanoprost, can delay surgery, or in some cases, maybe can be a primary therapy in mild to moderate severity glaucoma. So that's why I suggested in the conclusion. Thank you.
Thank you.
Thank you, Dr. Soki. Thank you, Dr. Dewi. Yeah. We have finished in the presentation. I berikan lagi sama panitia. Silakan.
Ya. Terima kasih kepada Dr. Kemala dan Dr. Syauki yang sudah berkenan menjadi juri pada hari ini. Ini sudah merupakan sesi terakhir kita hari ini. Nanti izin mengingatkan sekali lagi bahwa penilaian masih bisa kita buka sampai tanggal 12 Agustus 2023, Dokter. Ya. Selanjutnya kami minta izin untuk dokumentasi, Dokter. Ya. Di spotlight. Kita mulai, Dok. 1, 2, 3. Jadi, Dokter, terima kasih banyak atas kesempatannya, Dokter.
Ya, saya juga terima kasih ya.
Terima kasih, Dok.
Terima kasih pada panitia atau Soki, terima kasih.
Iya, terima kasih Bu Kumala, sama-sama Bu.
Ya, terima kasih banyak. Ya.
Saya izin live ya. Waalaikumsalam.
Izin.
Ya.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.